Hello, everyone, and welcome to the Zoom webinar, Understanding Hepatic Encephalopathy, Recognizing the Signs and Symptoms. Thank you so much for being here today. My name is Marissa, and I'm the Engagement Coordinator with Global Liver Institute, which is a nonprofit dedicated to empowering patient advocates. This webinar is part of the Tackling Liver Cancer Disparities series with the Health Council of South Florida and the Southeast Florida Cancer Control Collaborative. HCSF is a trusted regional organization dedicated to improving the health and wellness in Miami-Dade and Monroe counties for over 50 years. The Southeast Florida Cancer Control Collaborative is a voluntary network of healthcare providers, community organizations, and advocates working together to reduce the burden of cancer across Southeast Florida. In just a moment, we'll get started with the presentation, but before we begin, I just have a couple housekeeping items to go over. So just everyone is aware of the format. This webinar is kind of broken into two parts. The first part, we are going to watch a recorded presentation from our speaker, Dr. Richard Manch, which will be followed from a patient perspective from our wonderful patient advocate, Melanie Smith, who is here with us today. So she will be able to answer any questions that you might have at the end of her portion. Also, feel free to turn your camera on or off, whatever you feel most comfortable with. And with that, thank you so much for joining us. I'm just going to give a quick overview of who the speaker is and then hit play in the presentation. So the speaker is Dr. Richard Manch. He is the Chief of Hepatology at Arizona Liver Health, which he helped establish in 2017. He's a nationally recognized leader who has helped build Arizona's liver transplant programs, statewide outreach clinics, and innovative telehealth hepatology consultation services. He was also honored with the American Liver Foundation's 2020 Healthcare Visionary Lifetime Achievement Award. And with that, sit back and enjoy the presentation.
Okay, so I'm Richard Manch. I'm a clinical professor of medicine with the University of Arizona, hepatologist and co-founder of Arizona Liver Health, and medical director of the Viral Elimination Network Hepatitis C program. Today I'm going to speak to you about hepatic encephalopathy, which is a significant concern in taking care of patients with liver disease. It's very, very common and can be very effectively managed if managed appropriately. So we will start with some definitions. Hepatic encephalopathy specifically, this is the definition, potentially reversible. So this is often reversible, especially if we diagnose it and treat it appropriately. Neuropsychiatric abnormalities seen in patients with liver dysfunction or something called portosystemic shunting, which can be a manifestation of liver disease or it can be caused by other things. Then there's the term minimal hepatic encephalopathy. This refers to this same clinical syndrome, but it cannot frequently be detected clinically, so you have to kind of detect it. You have to do some things to find it. So it's a subclinical encephalopathy or mental status changes in patients with liver dysfunction that can be detected primarily with specialized neuropsychiatric tests. That sounds like a high-class word, but there's some simple ways that you can bring it out when you talk to patients. The other thing we should mention is this term decompensated cirrhosis. What does that mean? Well, cirrhosis, remember, is just a term we apply to the liver once it's experienced enough damage that it's heavily scarred. So a heavily scarred liver is cirrhosis or a cirrhotic liver. But if the liver is still functioning well, in other words, if the person that has cirrhosis couldn't be picked out of a crowd, looks healthy, functioning normally, no symptoms, we call that compensated cirrhosis. If they're already experiencing decline in their liver function, they're actually getting sick, then we call that decompensated cirrhosis. And that can be determined in a number of ways, but primarily it means the presence or absence of complications of liver disease, and some of those are listed at the bottom. Ascites, bleeding varices, which are varicose veins of the esophagus, encephalopathy, which is our discussion today, and a few other conditions that represent the patient starting to have decline in their liver function. So the patient with cirrhosis can go on for many years without decompensation. And when we manage patients with cirrhosis, our goal is to prevent them from decompensating, prevent them from getting worse, and finding ways to try to address the cause of their cirrhosis. So, what's behind this whole concept of encephalopathy? It has to do with how the body manages protein in the diet. So this diagram, I think, is on the one hand simplified, on the other hand can be a little bit confusing because the arrows are all going in different directions. But basically, as you consume protein in the diet, it gets broken down, and the liver has a very important role in breaking down protein into other proteins and other substances, some of which is eliminated in the urine, and some is eliminated through the bloodstream. And what happens when the liver function begins to decline? The patient becomes decompensated, as we were talking about. uh, the product of protein breakdown, which is ammonia, begins to accumulate in the blood, and some of it goes into the brain and causes this at least temporary dysfunction of the brain. So it can be very subtle, but it's considered a manifestation of ammonia building up. Sometimes they say ammonia intoxication. In other words, there's too much ammonia in the blood. Ammonia gets into the brain, and it causes the symptoms that will be and the problems with it we'll be talking about. So it's really quite common. Up to 45% of patients, once they have decline in their liver function, this will be one of the symptoms, one of the reasons that we say that they're decompensated. So if they start throwing up blood, if they turn yellow, those are signs of the liver starting to fail and decompensate. But this is also a symptom of decompensation. Can be the only sign, can be the first sign, often is the first sign that the patient all of a sudden or gradually, may be noticed more by others than by the person, starts to have difficulty with routine mental functions, even finding where they need to be at a certain time, maybe wandering through the house and forgetting, why they went into a certain room or picked up a particular item. So, if the patient still has fairly reasonable liver function, in other words, they're still compensated, that's the second bullet point here. There's a risk in time that they will show this symptom to decompensation. About 20% a year of patients with cirrhosis will begin to show this change. And up to 80% of patients with compensated cirrhosis could be found to have this minimal or the clinically non-apparent signs of hepatic encephalopathy, which we have to search for it. It won't be obvious to the patient or the family members. But as we mentioned, this is one of the things that signals that the patient's liver function, usually in a patient that's had cirrhosis for quite some period of time, is starting to worsen. So it's a signal that they're starting to decompensate, things are getting worse. And this is often the first point where they seek medical attention. These statistics are a little out of date, but they give you some idea that this particular complication, which very frequently drives patients into the hospital, is a big deal. Well over 100,000 hospitalizations per year, and it's an older number, so I think it's quite a bit higher, are related to hepatic encephalopathy. The stay in the hospital is often quite lengthy, can be over a week, and this will generate a huge amount of medical costs in the billions and billions of dollars. So this is a big deal as far as management of liver disease. It requires frequent hospitalizations. And actually, if it's severe enough, it sometimes moves patients more rapidly toward liver transplant. So this can be a reason why patients have to get a liver transplant, that they're so debilitated from hepatic encephalopathy. So very important. So this is a little bit academic. In other words, in routine clinical practice, we don't pay much attention to the type of hepatic encephalopathy. But suffice to say that the common type in the literature, in the medical literature anyway, it can be referred to as type C, the kind that's at the bottom of the screen there. The kind that's associated with cirrhosis and portal hypertension. Now, what does that mean? Hypertension means high pressure, and portal refers to the portal vein, the great big vein that goes right into the front of the liver, the front door of the liver, or that's why it's called the portal. The portal is a door. So that portal vein becomes the flow of blood from all your intestines, absorbing all the protein, all the food breakdown, goes into the liver, and that flow can be slowed because the liver gets more and more dense, more and more full of scar. So portal hypertension is a complication of cirrhosis, and it leads to this syndrome of encephalopathy and indication of decompensated cirrhosis. Now, the other two types, type A is much, much less common, and it's associated with what we call acute liver failure, which means someone suddenly goes into liver failure without a previous history of liver disease. This can be caused by some cases of hepatitis B. It's also seen if a patient either accidentally or intentionally takes too much acetaminophen, which is a common over-the-counter pain reliever, and the liver suddenly fails. And the patients often recover or may need a liver transplant. The third type, which is called type B here, is occurs in patients that have some redirection of the blood flow from the portal vein, and it can be done on purpose with something called a TIPS, which is abbreviated at the bottom, transjugular intrahepatic portal systemic shunt. This is actually a little shunt or a tube put inside the liver by an interventional radiologist to relieve the back pressure in the portal vein. So these are the three categories of causes of hepatic encephalopathy, but what we're really focused on is the type C, the kind that's associated with people that have cirrhosis that are starting to experience a worsening of their liver disease. There's a scaling system that is not really used clinically. In other words, if you look at medical records, you don't usually see this mentioned, but it's something to think about because it gives you an idea of the broad spectrum of encephalopathy from patients having none, um, uh, no manifestations of it, all the way to patients that come in deep coma. And even though that stage, that grade 4, which sounds very severe, coma, that can be reversed as well. And sometimes patients can be in deep coma, and once they're put in the proper treatment, which we'll talk about in a minute, they can wake up within a few hours and sit up in the end of the bed and say, why can't I go home? So it is reversible even in the severe cases, but what we often look for is the milder manifestation. So in a grade 1, patient may experience just a mild lack of awareness, a little bit of confusion, a shortened attention span. They may notice as they try to balance their checkbook, if anybody still does that anymore, they're having trouble with adding or subtracting simple arithmetic. The patient also may manifest a unique type of tremor or shaking of the hands. You can detect it in the feet as well, but it's harder to find it there. But in the extremities, we'll have a unique kind of tremor or shaking that is kind of an up and down or a flapping motion of the hands. So we sometimes call it the slang term liver flap. The medical term is asterixis. It's a flapping of the that can be elicited when the patient puts their hands flat out forward like they're going to stop a bus, and the hands flap up and down like they're waving goodbye to you. The grade 2 is more severe. The patient becomes noticeably lethargic, uh, disoriented, can be having trouble with bladder or bowel control. The behavior can be inappropriate. This shaking of the extremities, the hands, the flapping tremor of the hands can be worse. Speech can be slurred. The third stage is when they're sleepy but arousable, like almost like they're intoxicated. And they sometimes call this ammonia intoxication. They're grossly disoriented. Behavior becomes more severe. Um, and the reason that I highlighted the first two in red is the patient can still be detected and managed as an outpatient, but once they get to stage 3, they usually have to be hospitalized to get this under control. It becomes more serious and more dangerous. Typical scenario is maybe the patient's at home by themselves, they're on treatment, but the spouse is away all day at work. They come home at the end of the day and they discover that their spouse or significant other has become very confused, maybe has not been taking their medication during the day. So one of the things about patients that have been diagnosed with encephalopathy is they often need to have close access to a caregiver. Okay. So this just reminds us that this can wax and wane. It can good days and bad days. The green line at the bottom, that's minimal encephalopathy, so that's not clinically detectable unless we test for it. But the other two show you that the patient can go in and out of it. That's the yellow line. So at some periods of time, they can be normal and then can be very abnormal and kind of unpredictable pattern. And then this more persistent form where the patient is chronically encephalopathic. And some days it's worse, some days it's better, but it's always there. So high variability. The message here on this slide is high variability of the clinical syndrome. So how do we diagnose this? Well, it's really what we call a clinical diagnosis. So you can't really reliably diagnose it with a single blood test. Um, and this is a common medical error, medical mistake. In other words, this is an error that medical providers, doctors, and other people that take care of patients sometimes make this mistake. They order the ammonia blood test and they base the diagnosis of encephalopathy solely on the blood test. And a lot of patients and a lot of families are aware of the ammonia test. The doctors working in emergency departments frequently run this test without sufficient justification. So it's something that we in the liver field have been trying with difficulty to educate medical providers that if you do this blood test, we generally don't do it. In other words, the people most specialized in liver disease tend to avoid doing the ammonia blood test because it's misleading. So it has to be a clinical diagnosis. You have to examine the patient, talk to the patient, talk to the family, uh, and sometimes do some things to clarify. We might ask, are you sleeping differently? You find yourself sleeping in the daytime and awake at night. That some believe that can be one of the earliest signs of it. Do you find that in the recent months you've had more difficulty with adding or subtracting or a little bit of confusion? If you're driving, and I want to point out that people diagnosed with encephalopathy should not be driving. So if you've seen that advertisement where the patient, it's an advertisement for a treatment. I've seen it on TV, and I'm going to mention this. It's an advertisement for one of the treatments for encephalopathy that we'll talk about. And the patient is driving, but is confused and having trouble finding their way. I don't like the ad because people with this diagnosis should not be driving. It's a reason not to get behind the wheel. Um, One of the things that you have to do is what we call differential diagnosis, which means make sure it's not something else. Head trauma. So people with encephalopathy or with liver disease, or sometimes just people that are a little bit older or unstable, fall down. And you have to make sure it's not a head injury. Could be an infection of the central nervous system, such as meningitis or infectious encephalitis. Wernicke's encephalopathy is a type of mental disorder related to alcohol use. And another example is Wilson disease, which is a genetic disease where levels of copper are too high in the blood. And there's some other examples, but they're much less common than what we routinely seen in patients with cirrhosis. Now, what brings it on? It's often precipitated by non-compliance with lactulose. In other words, the patient's on treatment with lactulose, which loosens their stools and helps flush out the ammonia. But they don't like it, or they forget to take it, or they're by themselves all day, so they don't take it. So they stop taking it, or they run out of it. Another big one, which is the second medical error that I'll talk about, is being prescribed sedatives, sleeping medications, tranquilizers, or pain medications, particularly narcotics. These patients do have complaints. I can't sleep. I don't feel well. I'm agitated. I'm anxious. And it's often because they have liver disease and they have encephalopathy. So we don't want these patients to be put on any kind of sedatives, benzos, sleeping medications, tranquilizers, and especially narcotics. The liver can't handle these medications. It makes them worse. So this can often, the prescribing of these medications by medical providers to patients can often bring out or worsen the encephalopathy. I think that's an important point. Now, getting back to this issue of ammonia blood tests, they are often elevated in patients with encephalopathy, but that test is not useful in the diagnosis, and it's often elevated in patients with cirrhosis or even patients that don't have cirrhosis. Uh, uh, so, in the absence of encephalopathy, or in the absence of even liver disease, sometimes it's a non-specific blood test and it's not very accurate the way it's routinely done. If it's done from blood out of the vein, it's almost always inaccurate. So how high the ammonia level is in the blood doesn't correlate really with how bad the encephalopathy is. So like I said, people specialized in liver disease like myself, we don't order the test but we're always telling other medical providers, be careful if you order it, don't depend on it for diagnosis. And again, I can't stop emergency uh, emergency room providers from running this test. Someone comes in confused, they run this test, whether they've clarified that the patient even has liver disease or not. You can detect it with an EEG, a brainwave test, but that's rarely done. And there are specific changes that are mentioned here. If the encephalopathy is mild, it's not going to show on an EEG. If it's more severe, it may show what they call triphasic waves over the frontal lobes at 5 hertz rate in the early stages and slow delta wave activity in stage 4. But that's for the neurologists. That's an inpatient consideration. We're trying to figure out why a patient's confused. And then imaging of the brain is not going to show you anything except these very severe cases of acute liver failure or very severe encephalopathy. So testing with an MRI is really just to rule out brain trauma, such as bleeding in the brain from a fall. And EEG is rarely used. This is called a number connection test, and I do a simpler version of this. And it's actually supposed to be a time test, but I think doing it as a time test puts pressure on people. But I simply take a piece of paper and I might write down 10 numbers scattered erratically on a page and give them a pencil and say, start with 1 and draw a line connecting the 10 numbers. And this is a test that you might do when you're talking to a patient or family and you're trying to determine if this patient has encephalopathy or not. If you have normal brain function, you can do this. I don't agree with this timing protocol because again, I don't think I could do this with this many numbers. There's over 20 numbers here uh, in less than 30 seconds. I think I'm too compulsive and too worried about making a mistake. So I think I don't do it time. I frequently do this with a piece of paper, number connection test. There are some simple other things that aren't on the slide. For example, just ask the patient to write their signature. And if they can't do it, if their writing is all over the place, uh, that's an early loss of hand-eye coordination. That can bring it out. You're trying to decide, does this patient have encephalopathy or not? Uh, just draw a simple object on a piece of paper, like a five-pointed star, or if you choose a six-pointed star, and ask them to copy it. And it's kind of fun to do this because if the patient has encephalopathy, they just can't do it. So there's simple ways to bring out this minimal or difficult to detect encephalopathy. And if you diagnose it, you want to get the patient on treatment to keep them out of the hospital and keep them out of trouble. Um, so hepatic encephalopathy by definition, would require neuropsychological or neurophysiological testing. And that's basically what we're talking about. We're just not referring the patient for this. We do it routinely in the practice of medicine, seeing these patients. And a lot of it is looking for those clinical signs like the flapping tremor of the hands. But it definitely is a very important symptom for patients and families. It impairs their daily function. It really hurts their quality of life. If they're struggling with using their lactulose, they're worried about being near a restroom all the time, that kind of thing. Their driving skills are impaired. They should not be behind the wheel. This is often not done, and nobody likes to report anybody to the Department of Transportation or impair their ability to drive a car, but they should be advised not to drive unless this is very well controlled. It's important. That's why I don't like the TV ad. Um, there are no specific guidelines as far as the testing, although there are some pretty well accepted guidelines for treatment. And it's difficult to do some of the other specific testing that has been done, particularly that's used in research. But these simple tests we talked about can be easily done in the clinic. And as I mentioned, the last point there, many experts believe that the reversal of the sleep pattern can be the very earliest sign of hepatic encephalopathy, where people sleep in the daytime and are up at night. But it's not specific. A lot of other things can cause that as well. Now, if it's very severe, like I was mentioning, you get to stage 3, they generally have to go to the hospital. It's hard to get this turned around with the patient still at home. If it's mild, you can adjust the medications, and they may need even to be intubated and be in the ICU. But it's not unusual for them to come in deep coma and by the next day be ready to go home. But what happens is then they go home and the whole thing repeats itself. Maybe a week later, they stop the medications, they bounce back in the hospital. And I've had patients that have had 12 or 15 hospitalizations over a period of a year and a half for encephalopathy, to the point where the quality of life goes down to 0. Um, If it's an acute liver failure, such as an overdose or a hepatitis B case, they need to go straight to the hospital and may need to get a liver transplant. And always look for precipitating factors. Does the patient have an infection? Um, in fact, here they are. Are they starting to have bleeding from the intestine, which is common with liver failure patients? Are they infected somewhere? Do they have infection of the fluid in the abdomen, the ascites? That's spontaneous bacterial peritonitis. Have they been having these very large removals of fluid from the abdomen, which if they aren't carefully monitored and they take 10 or 12 or 15 liters out, that can upset the balance and cause encephalopathy. In very rare cases, it can be from eating too much protein. But I want to point out that we stress that people with this liver disease, cirrhosis, decompensated cirrhosis, they need to eat a lot of protein. So the old thinking that that we used to teach, to limit protein intake to prevent encephalopathy, that's no longer recommended. If they develop a thrombus, a clot in the portal vein, acutely, which is often hard to detect. This can be a cause. And then what I put in red is really the common causes that somebody gives them some sort of sedative, a benzo or some other kind of medicated narcotic. It can be with those patients that have a drinking challenge that they've started drinking again. Hypokalemia, you can have an imbalance of electrolytes or acid-base status. If the patient's on lactulose and they become constipated, they get worse. They have to adjust their lactose. We'll talk about that next. Or if they're not taking the medication. So we don't restrict protein. Patients need at least normal or increased protein intake to heal their livers. Some vegetable source proteins may be helpful if they're struggling with animal-based protein. Something called branched chain amino acids have been around for years, and this may be a way to get protein into the patient without worsening encephalopathy. I'll just mention it, but I don't think it's popular anymore. Some believe that probiotics, which you can get in yogurt and other sources, may help, especially if the patient has very minimal or early encephalopathy. And probiotics and things like yogurt are things that patients certainly like to do. And then we have two approved medical therapies, lactulose and rifaximin. And they're different and they work well together. Lactulose is a non-absorbed disaccharide or a sugar. It's a sugar that humans cannot break down, so it remains in the gut and ferments in the colon and loosens the stools and helps flush out the ammonia. And rifaximin is an antibiotic, very important in the treatment of encephalopathy. It's non-absorbed, it stays in the intestinal tract, changes the flora, and is very, very helpful with encephalopathy, but there's some problems with the use of it. If the patient has TIPS shunt, the shunt I talked about earlier, it can be narrowed or reversed or occluded. If it's working too well, the patient's not getting enough blood going through the liver. And of course, it can be one of the reasons that a patient will move on to liver transplant, which would obviously cure the liver disease. So talking about how lactulose works, it actually facilitates fermentation, which in the gut increases stool volume and helps flush the ammonia out of the patient. The mechanism of action is actually, even though we've used it for many, many years, is still not very well understood. But it is metabolized by the colon bacteria to short-chain fatty acids, which changes the pH of the stool. So that's actually a form of fermentation. So that's how it works. It's generic, it's cheap, but it has to be used appropriately. There is no standard dose to lactulose. This is my third medical error that I'll talk about. It's often said 15 to 45 milliliters a day or multiple doses, adjusted by mental status and bowel activity. But I have seen this dosed without the adjustment. We titrate it, we adjust the dose. You don't just keep taking it day in, day out. You may need more, you may need less. So the dose should be adjusted to achieve 2 to 3 soft stools a day and or the endpoint of controlling the encephalopathy. So typically 2 or 3 doses a day is required. In hospitalized patients, you can give it through a tube in the stomach or even through an enema. But it's often dosed improperly, even by experienced providers, which order it and they keep increasing the dose until they get the ammonia level down to normal. That should never, never, ever be done. That's not the way to do it. You adjust the dose. You have to talk to the patient or the caregiver and find out how many bowel movements they have and how well the treatment is working. So it's very effective, but it does cause, because it's a non-absorbed disaccharide, it does cause some bloating, some gas. And if the patient's getting diarrhea, they have to cut back the dose. So you do get into a dilemma sometimes where you can't control the patient with the lactulose. If you increase it, they get diarrhea. If you decrease it, then encephalopathy gets worse. So enter the second treatment, which is Xifaxan or rifaximin. That's the generic name, right? It's based on an antibiotic called rifamycin. It's not bioavailable, which means it's not absorbed, which is why we like it. So it changes the intestinal flora, changes the pH of the stool, and it's, I think, best used in conjunction with lactulose. So you start the patient on lactulose, you manage them appropriately, and if you can't get the job done with lactulose, then you prescribe Xifaxan. We do have some cost issues with it, which we are working hard over the years to resolve this. There's no alternative to it that's appropriate. So if you can't manage the patient adequately with lactulose, you have to use rifaximin. And because of the cost issues, and patients don't always understand that there are avenues where they can get it covered. They go to get the prescription filled and they're told, well, it's covered, but your copay is X amount of dollars, and it's often a very large number. This is a challenge that we've had over the years, which I think the situation's improving, and it's not unique. Obviously, the cost of medications throughout healthcare continues to be a challenge. Its indication currently is for prevention of recurrence. So to get a patient on this, get them approved, you have to indicate that you can't keep the patient under control with lactulose alone. So technically they have to have failed management with lactulose. That doesn't mean that you stop the lactulose once you get the rifaximin. It means that you add it on, and they usually continue lactulose, but they're much less dependent on it. Now, I believe that neomycin is still available for this. This is an alternative that is not recommended, but it used to be in wide use before we had rifaximin. Rifaximin was initially available for traveler's diarrhea, but then the new indication of chronic use for encephalopathy has been a real game changer. But because of cost, some patients get prescribed neomycin. It's also a non-absorbed antibiotic, but it's not as efficiently non-absorbed as rifaximin. So some of it does absorb into the body and can damage the hearing and the kidneys. So patients have become deaf or have gotten liver failure from chronic use of neomycin. So it's not recommended, should not be used. To wrap it up, hepatic encephalopathy is commonly seen in patients with cirrhosis, but it's often overdiagnosed or misdiagnosed or mismanaged. Reduced ammonia detoxification due to liver dysfunction and or shunting of the blood away from the portal vein are the physiologic reasons why this occurs. It's a clinical diagnosis, not a laboratory diagnosis. You cannot depend on blood ammonia levels for diagnosis. Protein restriction is no longer recommended, has not been recommended for years. Patients with cirrhosis need increased protein. Any acute episode of hepatic encephalopathy warrants a thorough evaluation for what may have instigated it, looking for particularly infections or inappropriate use of sedatives, narcotics, sleeping medications. And then the mainstays of treatment continue to be initially lactulose and the very frequent addition of rifaximin if lactulose is not adequate for treatment. But recurrent episodes, constant relapsing of worsening of encephalopathy, patients making trips back and forth to the hospital are common and very costly to the healthcare system. So with that, I will complete the discussion and thank you all for listening.
That concludes our first part of the webinar, and now I'll pass it on to Melanie for her to introduce herself and share her story.
Sure. Hi, thank you for asking me to be here. My name is Melanie Smith, and I am from Kansas. I have MASH-related cirrhosis and was diagnosed with that in 2009. 2011, I made the decision with my family that because of how significant it was, that I needed to step back, and I left my job where I worked with adults with developmental disabilities for almost 2 decades. And at that point, in 2013, I had come to find out I had my first hepatic encephalopathy episode. For me, I think, just as Dr. Manch mentioned, it was probably earlier on. I just did not recognize it. For me, it was the reverse daytime sleep situation. I think that was probably where I started having issues. Could not go to sleep at night. I would go to bed and I would just lay there. But then during the daytime, I could sleep for 14 hours. I was so tired all of the time. And even when I woke up, I could have went back to bed. I felt tired all of the time, and never felt rejuvenated, so to speak. For me, my first episode was actually, I've shared it several times, was my husband came in. I have 2, now they're adult sons. At that time, they were 12 and 14, and my 12-year-old had a dance, and he's like, Melanie, do you want to go pick him up from the dance? And I said, yeah, let's go. He gets me into the car, and I became adamant that he was taking me to Walmart to go buy Lee press-on fingernails, of all the things. And I don't wear Lee press-on fingernails, but I was adamant at midnight that we are going to go buy me Lee press-on, and that's not who I am. So he said, well, let me go pick up our son. We went and picked up our son at the dance. We get to Walmart, and my son and my husband could not get me out of Walmart. They tried, no matter what they did, they could not get me out. My son was so embarrassed, he walked off from me. And my husband stuck with me. They couldn't figure out what was going on with me. It was like had drank. It was like and I am not never was a drinker, but that is what it was like for them, is what they described. And looking back, I don't recall anything about that evening. The only thing I remember is there is a slight sense of where I crashed into this a big, huge display of candles. And I kind of remember a smell of all these candles. Other than that, I don't have any recollection of that evening, but I do know that 3 weeks goes by and it was Thanksgiving, and we're getting ready to start decorating for Christmas. And my youngest was at my sister-in-law's house for Thanksgiving, and my husband starts bringing in the Christmas decorations, and he says, "Oh, we got a bunch of stuff out in the car from when that night that you went and bought stuff." And I said, "I didn't buy anything." And he says, "Oh, yes, you did. You bought a lot of stuff." And so he goes out to the car and he brings in all these bags of junk, including Lee press-on fingernails. And I had spent over $335 on junk. Um, and I was so angry. I knew I didn't buy that. I just was so adamant that I didn't buy that. And so I remember calling my youngest son and saying, "Did I do this?" And he said, "Mom, you did." And at that point, I lost it. I felt like my world had just imploded on itself, that where I can no longer mentally feel like I'm in control of my life. I was humiliated. I am a professional within the community. I had ran my own business, and here I am crashing into these huge displays at Walmart. They can't get me out. They get me to the car that evening, apparently. And I had fallen asleep and I was so out of it, they could hardly wake me up. They get me into the house and I slept for almost 2 days. They just thought I was sick and I was tired, but they did not know about HE. My what I did that after my son said, "Mom, you did do that," is I went on, I had a support group where I have a group of friends that we talked about MASH, related cirrhosis. It was NASH at that time. And I was sharing my story with them, and they said, "Melanie, I think you have HE. What you're describing is hepatic encephalopathy. You need to go to your doctor." And so I went to my hepatologist and shared the story. And that is where I started on my lactulose. And it was not enough for me. I continued to have episodes where I would break through and have issues. And at that point, I would go to my doctor and she put me on Xifaxan. And just as everyone said, or the doctor alluded to, financially, it was an enormous cost. And the deductible that I was able to get through the patient assistance program, there is resources out there, and it made a huge difference in the quality of my life. But I had to be consistent with the lactulose and my Xifaxan, and that really made a quality of life difference for me. It was devastating to lose my ability to drive. For 3 years, I was so episodic that I literally stayed home most of the time. My speech would be slurred. I couldn't recall the names of my family members. I remember staring at my niece and thinking, I know she's my brother's daughter. And I'm sitting there thinking, yes, she's the last daughter, and I know I should know her name. Well, she's named after me. My own niece, who's named after me, I could not process her name. And these situations are so degrading, so difficult. And I think, as my husband, was my caregiver, would say, is he was my rock. And I am very blessed to have a caregiver who is my rock. But if you don't, it's very important to work with the people that are around you, to let them know about your condition, so that they can kind of say, "Hey, I think something's off today," and to build a relationship with people that can kind of support you. It is important to have those people in your life. I run a support group for people with hepatic encephalopathy, and we can't be an island unto our own. We have to have a community of people and support. I think this is my story, and I'll be glad to answer any questions. So I will just turn it back to you and go from there.
Yeah, thank you, Melanie, for such a powerful story. And we really appreciate everything that you do to create a community for HE and work
Thank
with BLI.
I see that question. Is it, you want me to answer it, or Marissa?
Yeah, go for it.
Okay. I think the best answer I can give you is I don't know if rheumatoid arthritis affects the sugar will affect that. The best support you can do is talk to a pharmacist and or your primary care doctor. They gave you 3 doses in the hospital and it didn't work. And it was lactulose. Lactulose works. It is a sugar that it will never, people say it's going to affect your diabetes. It will not affect your blood sugars in most cases. So I don't know how it would work with RA. I think a pharmacist and or your primary care doctor would be the best support. If you do have true hepatic encephalopathy, you might ask your doctor about rifaximin and see if that might be a good secondary medication to add on to that. For me, that is what made the difference. I was not okay with the lactulose alone. You do take Xifaxan, okay. And how is that working for you? Okay. Well, I think those are the things that work well for me. Also making sure you don't have an infection. I just went through an episode myself 2 weeks ago. I had a urinary tract infection. And when you do get those infections, it will make your HE flare up. So it's very, very important that you pay attention to your body. Oh, you're allergic to it. Okay. Yeah, I think probably in your case, given what you're sharing with me, the best support, the best answer I can do is work with your doctor, going in and talking to a pharmacist and your hepatologist. And the doctor is correct that, as he talked about, the sleep medications will exacerbate HE. And that's from my own personal experience as well. That episode that I talked to you about, where I was at Walmart, I was on a medication that helped me sleep at night. And it impacted me greatly. So I had to work with my pharmacist and my doctor. A lot of those things, no one individual, my story is not going to be able to help you. You're just going to have to work with your doctor individually. I can tell you my story and share it with you, but the best support truly comes going with your doctor. And if you're not getting your answer, go seek a second opinion. And that is, don't give up, be your best advocate, go talk to another doctor, to another pharmacist, be persistent. If you have a caregiver, bring your caregiver along. My husband is my rock, and I would drag him along. I've had my dad come with me, because if you have HE, you don't remember things, and we really do need our caregivers. And so if you're a caregiver here, thank you for all that you do for us. I hope I answered your question. It's about as best I can give to you. That's very typical. When as I shared, you don't remember things. And when you have those HE episodes, you're not going to. The only thing that I could remember is, like I said, the smell of those candles. And I think that's typical. Our senses are sometimes strong. So we're not going to remember things. It's why we have to have caregivers and people around us to support us. Marissa, thank you for having me. I appreciate it. I appreciate GLI and everybody here.
We appreciate you. Thank you so much for being here.